Perfect. Hi, everybody. Welcome back. Hope you had a good break.
Yes, yes.
I'm sorry, I think I messed up on time a little bit. I thought I'm used to the seminar timing of 75 minutes being your sort of drop dead deadline for stopping everything, whatever you do. So I think I was working with that in mind, and clearly that wasn't working. Okay. So this next one, there were a couple of topics that I had promised that we will touch upon when we come back to this one. So I will want to come and touch upon a bunch of those, including when we talked about service selection and stuff. So the topic for the next couple of hours is to think about the structure of incentives. So after the Nobel Prize a few years ago that Oliver Hartnett got, is the contract theory got a lot of attention. In particular, principal agent models received a bunch of attention for a few years, so that was good. This particular research project, we started to try and it was motivated by a policy question. But for this audience, what I'll try to do is keep the policy context, but focus a bit more on the academic questions that are important from the perspective of empirical contract theory as we apply it in development. Okay, three things we are going to be looking at. We will be talking a lot about performance incentives, a little bit on contract theory. I won't bore you too much with the details of the basic models. I'm sure many of you, those who know it very well, and those who don't know the details of a principal agent model, this is probably not going to be enough time to get into those details. So I will keep it fairly superficial, but I will get into some of the operational challenges in sort of implementing that theory and the predictions from the theory that we will run into. And then I do want to, time permitting, also talk a little bit about some of the behavioral lessons we've learned along the way, trying to tie in lessons from economics and psychology in this case. Okay, so the quick primer on pay for performance is, let me just make notes on what I need to tell you. Okay, mixed notes on this is that people have very, very strong opinions when it comes to pay for performance. And it's one of those topics, especially in policy circles, you will find a lot of people who really believe that this is the best thing since sliced bread. Everything, every problem can be solved with a pay for performance. All you have to do is incentives and performance, and you're done. There are others who will believe that this is the worst thing ever because it distorts all kinds of problems, creates all kinds of distortionary responses, and that no possible good can come out of it. But clearly that cannot be true, right? You can't have such polar views on everything. There's some middle ground where maybe it does some good, maybe it doesn't do so well. So the point I want to first bring to your attention is that the evidence on the effect of pay for performance as it has been implemented in whether in education or health settings, and we'll focus a lot more on health in this case as well again, has been less than strong. Partly because it's really hard to do very good empirical work in this setting. Partly also because we are actually keeping pace. We are trying to keep pace with the theory development. So I'll tell you a little bit more on the theory part, but it's essentially our empirical studies are fairly basic compared to the amount of advanced work we've done on the theory side, which is another way of saying if any of you are graduate students in particular trying to look for topics, this is very open. This area is ripe for empirical research. You can open up any good contract theory textbook, look for stuff that's been written up on the theory aspects, and then look for empirical tests of that theory, and you'll find there's relatively wide open spaces that you can innovate in. So highly encourage you to push boundaries on that one. Great. So this is what we'll be doing is doing a little bit about thinking about pay for performance in the context of the principal agent framework, and then bring in some of the challenges that contract theory has told us do exist in the real world when we are trying to pay people to get work done. The evidence obviously is mixed, as I told you, but my caution to you right now is let's not throw the baby out with the bathwater quite yet. It's not all bad and it's not all great either. But bringing this to India, there's relatively little work on performance incentives in India, in the development sector, in across the board, but also in development in particular. A couple of examples stand out. There's the work that Karthik Muralidharan and others have done with teacher incentives. So there's some work in the education sector. Prakash Singh and others did this really interesting study looking at Anganwadi workers. And there are a few other small ones looking at incentives to doctors or nurses and stuff, but not so much in the literature on contract theory per se. So I must point out, there are two strands of literature that come very close here. There is the health, and I'm sure in education this happens as well. I'm more familiar with health. The health policy, public health literature that has looked at incentives and payments. They look at it in that body of literature, to the extent that it exists, tends to look at it in a much more, I gave doctors X amount of money, they did Y, rather than trying to break it down into the structure of the contract and trying to understand the contract theory aspects of it. So it's not that it's any less or more reduced form than what I'm about to show you, but it doesn't get into the aspects that we would worry about as a community. Okay, so let's think about what we know about the theory. And I've referenced a bunch of papers here, especially that first bullet point. Those of you who are interested in the topic or want to get into the topic, I would highly, highly urge you to look at all of those papers, as well as some of the other Canis Prendergast papers that are referenced here. So I know that the audience includes a mix of people who are experts as well as not. So just bear with me. There are a bunch of terminology things in here that I need to explain for us to understand why this question is important. Okay, so performance incentives have the possibility, or they open up an opportunity for us to correct principal-agent problems. What does that mean? It means whenever you have a transaction where one person is hiring another to get something done, in this case, for simplicity, let's say, I want someone to build a wall, and I'm going to hire a worker who's going to be building a wall for me, and I need to pay this worker. I could pay the worker based on a bunch of different options. I could pay them an hourly wage, a daily wage, a wage that's tied to the number of bricks, the number of walls, all kinds of things. But the simple idea is the agent, in this case the worker, the agent faces all the costs of effort that has to be done, and I am going to decide how much to pay the worker based on how much it's worth it to me, how much that wall is worth it to me. Right? So you can already start seeing that the value that I get from the production of the worker is going to be what's intuitively going to set the wage for this worker. Right? The worker, on the other hand, if I told them that you're in a tenured position and you will get X amount of money no matter what, then chances are they're going to shirk, because at this point, wage has been held fixed, and any effort at that point is just costly to the worker. Right? So this is the beginning of what we will want to think about as the underlying fundamental problem in the principal-agent problem. The principal, if you sort of want to make it really distortionary, the principal would like the agent to work right until the marginal product of the labor is right up to zero. Like keep working till the marginal product of labor, that extra hour of labor is not going to produce anything else. That's where you stop. But it turns out that extra last hour of labor is going to be extremely costly. Maybe it's because that's the 15th hour of the day that the poor guy has been working. Maybe it's because there are other things to do in life, right? Because you always want to think about the opportunity cost and stuff. So this is the birth of the central crux of the problem. By providing performance incentives, I can now make it, for lack of a better simple term, I can make it more palatable for my worker to work more for me at the margin. The first hour might not work, the second hour might not work, but that last marginal hour, if I have a performance incentive that's tied to somehow make it more attractive for the performer, for the agent, for the worker to work a few more hours, put a little more inputs, it might help. Right? So this is good. Fairly simple. There's a lot more nuances in there, but if we have to do it, how can we do it? It turns out the example I gave you, the wall, could be done two different ways. One is I could just say, I'm going to reward this worker based on inputs. That is to say, I will stand there and work and observe how many hours this worker works, how many bricks he's laid on the wall and how many slabs of cement he's used or whatnot they've used, and all of these inputs together is basically how I'm going to compensate them. The more they work, the more they get paid, right? This is good, except the problem with this is now a central concept from contract theory, is in order for us to reward people based on inputs, these inputs need to be observable and verifiable. Observability and verifiability, when these two criterions fail, then the contract itself would not be enforceable, right? What does that mean? Let's say the worker says, I've built a wall, but it's an invisible wall. It's like, remember the story of the invisible suit that the emperor was wearing? Well, if it's not observable, we can't basically agree on the terms of a contract, because the worker would say, look, I've built you this big, beautiful wall. Now you got to pay for me. And I can say, I can't observe it because for whatever reasons, or maybe it's a wall that's built in a forest and I can never go there. It's like that old saying, if a tree falls in the forest, did it really fall if no one saw it, right? So the observability clause actually is really, really important. I'll come to the implication of that for us in a second. Okay, so just put a pin on that one. The second thing is, even if it's observable, if it's not verifiable, contracts break down. Because, so for example, if I said, I want a wall to be built and it needs to have these many inputs. It needs to have 50,000 bricks and it needs to have 17,000 kilos of cement. I'm just making random numbers up. The bricks might be easy. I could go up there and start counting the bricks and verify that, look, okay, you told me you will give me a wall with X number of bricks, it's there. But the cement, you might have skimmed on the cement. How do I know how much cement was used? Right? So if that verifiability is not there, again, you might have put in all the effort and input you wanted to do. This time, I'm still talking about inputs that are tangible. Even with something tangible like concrete cement, if I cannot verify that the amount you claim was used, it can break, the contract breaks down. Now, let's turn this into effort. Right? We used bricks and mortar and stuff because it was easier. Human effort is different. If any two of us, you and me, we stand together right next to each other and say, let's build a wall for a whole day, what is 100% effort? Is it 100% of a human global maxima? Is it your 100%? Is it my 100%? How are we going to define that we have exerted 100% effort, right? So now already we are talking about an input, in this case, which is effort, which needs to be observable, and we need to be able to verify that it was hitting some level of maximum. Otherwise, it's going to be very difficult to introduce this concept, the contract. So essentially what we are saying is, even for something very simple like an input-based contract, if you cannot monitor the inputs, you cannot observe and verify them, and verifiability, the easiest way to think of it is, if you take this to a court of law, can the court decide that, yes, your argument about having exerted X amount of effort versus mine saying, no, it was X minus delta, is going to be right? If the court cannot adjudicate that particular argument, then we know we have a verifiability problem, right? So here's the way to think about it. In contract theory, we can basically then think about the element of risk. With input-based contracts, if inputs are observable and verifiable, then there is no risk involved. In some sense, we can think of this as a possibly first best. I say possibly first because you need several things in order to become a first best. What is the first best? It's useful to define what the first best is. In the context of the wall, what that means is I, as the principal, should know perfectly well what the expected output should have looked like. I should know what kinds of input go into producing this output, right? So in other words, I'm saying I should have full knowledge of the production frontier or production function here. I should be able to define what that production possibility frontier looks like, and then define inputs that meet that frontier at each of the inputs that go in. At that point, after that, I have that level of knowledge, I can turn to the worker and say, look, here are the 7 different inputs, and these are the rates at which I need you to apply them. I can perfectly monitor the inputs because there are no observable, verifiable problems here. You go ahead, do it. I give you wages. So basically, I can pay them piece wages at that point. There's no risk involved for the agent. Agent is happy. As long as the participation constraint is met, there's no problem of incentive compatibility. But all the things I told you are going to break down in the real world, right? Every single one by one, will break down. Which means if I'm going to be, even in a first best world, if I'm going to be thinking about an input-based contract, I, as the principal, am going to bear all the risk on this contract, okay? An output-based contract will basically say, well, hold on. All of these inputs have to go into producing this wall, but I have no idea how to produce a wall. Ask me to write down a study design for a complicated research project, maybe I can help you. But a wall, I have no idea, right? Many of us in the room might say, well, I have no idea. Wall to me means Pink Floyd, but not like actually putting a brick and mortar wall. So essentially what we are saying is, if the agent, the worker, knows the production function better than you as the principal, and maybe the agent also knows that actually building a wall in Kerala would have to take account of the humidity there, and therefore will need to add less water while making the concrete, versus making that same wall in, say, Rajasthan, the deserts of Rajasthan, would be more water because you have to work differently in those arid conditions. Now, essentially what we are saying is better knowledge of the production function. If the principal doesn't know the exact details of the production function and the agent knows better, perhaps an output contract could help. But remember, with the output contract, now what we have to do is think about the risk involved. That is, the agent has to now face the risk. The worker builds the wall collapses. Principal says, I don't care what you did. Look, the wall is not good enough. It's all your responsibility. Immediately, we have some predictions we can start working with, right? So we can start, I will come back to these predictions later, but just these set of conditions that we laid out, and actually the Prendergast paper that I've referenced here is a really good one if you want to sort of think about this some more. These issues of how observability, verifiability, and knowledge of the production function help us sort of think differently about input versus output-based contracts. Right? So from a theory perspective, we can write down a set of conditions. Okay, all right. So then the question is, this is fine. All of the literature so far, going right until the Prendergast, and Kenneth Prendergast has written a number of theory papers about this, which was a starting point for our research. All of these assume that the worker, in this case the agent, is a homogeneous type of an agent. There's only one type of an agent. But just as I started with that example, you and I trying to build a wall, and you might be able to do better than I can, tells us that there are different types of agents, different types of skills that workers have. Whether it's students, whether it's professors, we all have this problem, right? And so the question that becomes really useful in this case is, can we say something about the structure of contracts and what type of workers might respond better to different types of contracts? And so the empirical, the theory, what it points us towards is the following. If an agent is a low-skilled worker, right, who is not able to innovate, which is another way of saying the agent might not necessarily either know the production function or be able to understand the contextual difficulties around which their production function is to operate, and therefore you have to give them instructions, right? That's a low-skilled worker. They're not going to innovate. If that low-skilled worker is given an input or an output-based contract, what happens? Versus a high-skilled worker who is aware of the technology that they're working with, the production function and the constraints and everything, and if you gave them a choice between input and output-based contracts, right? So now so this is the broad structure. Do agents perform better when you give them the freedom to innovate, or if you tell them what to do? Right? So think of yourself as the CEO of a company, and you are asking this problem. Should I give directives to all my employees, or should I be telling them, you guys have the freedom, you need to achieve this task and just do it. I don't care how you do it, come back with the results. Show me the results, right? And now if you think about different types of workers in your company, as you're the CEO, you might realize that you can't leave everyone to face the same challenge. You might have to deal with them differently. So intuitively, that's where we're going with it. Okay, so now let's switch gears a little bit and think about what we know about pay for performance. Pay for performance globally has been growing a lot. In fact, it's growing almost exponentially. A couple of years ago, when we started doing this project, at one point, there were national level pay for performance programs going on simultaneously in over 40, 45 countries. And this was all partly because of the early results that came from this experiment in health in particular, that came from this study that Paul Gertler and others had done in Rwanda. And then what they did was they introduced this pay for performance experiment, and it found fairly large effects on a subset of outcomes. And to be fair, that study, although despite all the sort of attention it got, it had some major flaws. And the major flaw was that it rewarded 24 outcomes, but reported the outcome on only 8. That's one of it. And the second part of that is that it was always sort of it was assessed based on the experimental data available. And then there are all these other, if you try to publish that study today, you would run into major problems because of multiple outcomes and whatnot. But for the time, it was a very useful study, and it created this giant interest in the field of pay for performance. Most of the pay for performance globally look at some measures of service delivery. Right? They're not looking at outcomes. There are very few pay for performance studies globally, or efforts even, which say, what I really care about as a policymaker is health. You make my population healthy, I will pay you. That's not what these programs look like. They rarely will say, I will give hospital X a large amount of money if you reduce maternal mortality by this much. If you keep children from getting sick, if you improve neonatal mortality, or any of these outcomes. Instead, these are typically of the fashion that they'll say, increase the number of patients who show adherence to hypertension prevention programs, or increase the number of patients who are managing their diabetes better. Right? So now what that translates into is how many visits, how many medications, how many tests. So that's what you get. And especially in countries like the US, what you see is this giant increase in the number of tests and procedures, but the health outcomes per se have not really improved. So globally, what we find is that the evidence has been kind of sort of mixed. There are a few studies that find fairly large effects, but for the most part, it's also been a little unsatisfying. Part of this problem has also been especially in endemic situations, the lower middle income country situation. We know that there is this large no-do gap. That is, even healthcare, even in settings where you think that the market should be working, healthcare providers do a lot less than what they know how to do. Right? So what it suggests is that they know that they are supposed to do procedures ABC. They know they're supposed to do these investigative steps, give the right treatment when you ask them. When you observe what they do, they don't do all of those things. And that no-do gap is a very clear signal of something that's preventing providers from doing better. And the question then is, can we use these performance incentives to be able to do something better? So here what I'm trying to do is just a little more structure so that we can get to the testable implication. The model is in the paper, you can look at that, but I'll just lead you through the intuition here. The simple idea here is that there are two types of agents, and they have high and low levels of skills. And based on these high and low levels of skills, they are trying to produce some health outcome, right? So they're going to be exerting some amount of effort, and there's this theta, which is essentially our productivity shifter. It basically tells me how useful my effort is in going to be producing this outcome. So it's like saying, I'm going to be building a wall, and I'm going to exert all this effort to put bricks up. How productive is this effort? Like at some point, you're thinking about what is the productivity of my effort, right? So that's my belief, theta. And as I build it, is it going to turn into a solid wall or not? So you and I might differ in our own beliefs about how effective our effort is. You might change that slightly to think about our understanding of the underlying production function. That is, I'm thinking now about how effective is my effort in converting that effort into a health outcome that I care about. Now, the thing is that these beliefs might be very hyper-local. Like these thetas that I'm thinking about, these could be very hyper-local, just like I said about using more water when I'm making the concrete mixture in Rajasthan versus in Kerala, right? And because the principals do not know this, Principals might give input contracts that are inefficiently high or low levels of effort, right? So if I as a principal, I'm going to write the same input contract for my laborers, I might end up giving them or directives to put in an inefficient levels of effort simply because my petas are all wrong, right? In other words, the principals can now basically reward inputs, but then the risk of this contract is going to be lying upon me, which is the same point I told you earlier. Same thing happens with an output contract. Now, the output contract is going to be characterized by risk, which the agent has to fully bear. But at the same time, if the providers have correct beliefs about productivity shifters, they can basically choose, they can give them a compensating wage premium for these risks. They can tell the agents that, look, you need to work in these settings. I know it's risky. I can pay you more. You do what you have to do to achieve this. Once you think of input and output contracts in this manner, you'll arrive at a testable implication. That is, essentially the performance of my agent will depend on the provider's skills in the output contract. And in the input contract, it's going to be independent of the skill. The way simply to think about it is, you and I, if you have to leave aside the psychological motivation part of it, right? For a second, let's assume that we are working purely as economic agents. You and I are two different types of agents. You are high skill and I'm low skill. We are both paid on inputs. At the point where your marginal effort is no longer worth it, you're going to stop. That's going to be the same stopping point for me as well in the input contract. So our performance should not vary. On the output contract, you are higher skilled, so you're able to innovate and you will be able to gain from that innovation. Therefore, you will do more and you will get higher rewards. I, on the other hand, get less. So it's a testable implication. I did a little bit of hand waving in all of this. And this is a very important hand waving, actually. So what is this? In the perfect world, the contract that we would think about would be different. That is, we would take two contracts and go to each agent and say, hey, look, which one of these two do you want? Or better than that, if you are the principal, you might actually look at every single agent and then make that decision that this is a high-skilled agent versus a low-skilled agent, and then you might decide which one to offer. We can't do that. We couldn't do that, on the other hand, right? So we are not going to be trying to think about selection into contracts, which is actually really important. In the real world, agents do choose which kind of contract, which kind of wage structure they want to be under. We are not going to do that. We are going to step away from that and only test this particular implication that we tell you about. So this is a paper. It's been conditionally accepted. I have to send them some data code finally, and it's going to be coming out someday in the AJ Applied. But the working paper is available. I think we sent the link to you. So this is joint work with Grant Miller and Marcos Vera Hernandez, and Catherine Donato and Yulia were both former students who are now gainfully employed. So I'm very happy for them. Great. So this was made possible with funding from 3IE, DFID India, and the World Bank and the government of Karnataka. And we did this in project standing work job in implementing the study as well as collecting data and stuff. Everything from give vouchers to mothers, to bring mothers to deliver them in hospitals, to do public-private contracting and stuff. So when we started this study, it was a three-pronged study in multiple states. So the starting point was the state of Gujarat, where we were evaluating what was then called the Chiranjeevi Yojana. It still exists, but it's different now. Chiranjeevi was one of the first major public-private partnerships in India. It got all these awards from the Singapore Economic Development Council for innovation and whatnot, because what they were doing was very different from what Indian government was doing at the time, which the government of India was trying to promote this program called Janani Suraksha, which was getting mothers to come into public sector hospitals and deliver babies there. Gujarat said, wait, hold on. We don't have public sector hospitals, and we don't have hospitals that have enough doctors. In fact, at that time when this policy decision was being made, I think this is the early 2000s, they had 12 OBGYNs, the number sticks in my head because it's so stark, 12 obstetricians in the entire state of Gujarat outside of the big cities. That's all they had. So they said there is no point in doing a program like Janani Suraksha and bringing mothers into hospitals that are publicly owned but poorly staffed. Instead, Gujarat, being the very vibrant pro-private industry type of a setting that it was, they already had this long history of a very vibrant private sector delivering care. So the government said, why try to duplicate this? Instead, can we come up with a program that contracts with the private sector hospitals and lets the patient go to whichever hospital they want and deliver their babies there. We just pay the private sector hospital. Right? So now you can already see this contracting thing is coming into picture here. Well, it turned out, so despite all the effort, all the awards they got, the Gujarat government, then Principal Secretary Amarjit Singh, he had called us in and said, let's do an evaluation of the program. To our surprise, what we found that the program had a zero effect. It had no effect at all. Once you took the secular trends into account and you took into account the fact that the averages were changing across the state, regardless of whether the program was implemented or not. What it told us, however, is once you start rewarding hospitals on volume, volume is what you get, right? So instead of all 100 of us going to 10 different hospitals, when you start rewarding some hospitals, they suck away from others. And that substitution effect is basically what's going to happen. So you want to pay for volumes, you get volumes. You might not get any outcomes. And so that's where, when we were working with the Karnataka government, we said, if you're going to try to replicate something like the Chiranjeevi, please hold on. Maybe this is where we should stop and not just do it again because Gujarat is doing so. Instead, we should run a clear policy experiment that will tell us what to do. The point here simply is that this was in the context where at least one state wanted to contract with private sector doctors across the state in order to think, can I improve outcomes? Right? So Karnataka was open to this idea that let's not pay doctors simply to increase the number of deliveries, but can we think about how we can structure these contracts to improve the key outcomes that can be affected in this healthcare setting, which is an OBGYN hospital, nursing home as we call it sometimes. Okay, so the field experiment was to randomize 3 types of performance contracts. The first one was a rewards based on outputs. We picked 4 outputs, and I'm sorry, there's going to be a lot of medical terminology and details of specific conditions. You'll have to bear with me because these are important for how we understand our results as well. Okay? So PPH, which is the #1 killer of mothers during childbirth, postpartum hemorrhage. This happens typically when mother has delivered a baby, and usually if the placenta is not delivered intact, or there's some parts of it, or because of a whole bunch of other reasons, the bleeding does not stop. Postpartum hemorrhage is basically bleeding after pregnancy, after delivery. And that is the #1 cause of maternal mortality globally, and the biggest ticket item, if you will. The second one is sepsis, which is basically can develop a number of days after the delivery happens. Oh, I should also point out, PPH does not necessarily mean it has to happen on the same hour or the day. There is primary and secondary PPH. It can go on to up to a week. So the mother goes home thinking the bleeding is normal, and she's like constantly bleeding little. At some point, it gets to a point where it's too late to save her. So that's PPH. Sepsis is basically you get an infection, a bacterial infection typically in this case, and it can lead to septicemia, and it can be really terrible. Again, can kill. The last 2 are peculiar. Preeclampsia is something that it's basically, think of it as a hypertensive disease that women develop during their pregnancy. It's basically hypertension that happens. It's not something the doctor can control. It's not something the doctor can prevent either. But the reason why we put it in there is because there's a lot of concerns about multitasking in the literature on performance incentives. And the simple idea is doctors are supposed to take care of these 4 or 5 important things. If I reward only 2 of them, and these are fairly large rewards, there's the risk that they might divert attention away from the other 2, which are clinically important but are not financially rewarded at this point. Right? So that was the reason why preeclampsia was included, not because it's something the doctor can necessarily cure or prevent, but they can manage. And at least this will prevent them from being distracted too much away from there. We'll look at the evidence on that as well. And the last one is neonatal mortality, which Two reasons why it didn't make any sense to include here. One is the sample sizes are trivial, and there's just no way we would have ever found anything. But the second thing is that in India, the law is such that if the child is actually serious, they're supposed to call pediatric references or send it over to a pediatrician. The obstetrician who delivers the baby and the pediatrician usually are not the same person. They're two separate people. However, we are rewarding now the OBGYNs, the person who's delivering the baby, for neonatal mortality outcomes. Again, this is because we were worried about multitasking. Is in the study, even if the effect is small, if it turned out that doctors started ignoring the children because now they're focused on the mothers to earn more money, that would be terrible. So we said, even though if you're going to lose some money in the process, it's still worth doing. Let's just keep it there. So all of this is why I needed to give you some background. You'll see why it's relevant later. The second group of contracts was just given the WHO Government of India guidelines. They had all these pretty brochures about what you should do. It runs into several pages. And we would tell them that the rewards are based on adherence to these contracts. And the third group is the control. They get the same brochure, but we don't tell them that they're going to be paid based on that. They are just told that they are part of the study that's looking at strategies to improve maternal and child health outcomes in their areas, and that we'll be following their patients who come to them, and we'll be interviewing them at some point. The same information that we give everyone. We even made them sign an agreement without the incentive parts of it, so that the act of them actually signing a piece of paper, they take it seriously. We went back to do all the participation meetings and stuff. The participation payments, again, it's almost once every couple of months, we would show up there and have management style meetings with them to understand what kinds of strategies they are adopting, because we want to think about innovation, remember, in this study. So we were trying to collect information about what they're doing. And in every interaction we had with them, we gave each doctor 2,500 rupees. And the reason to give them that money was to tell them that, look, we are serious. When we told you, you have a chance to make up to 1.5 lakhs at the end of the year if you show improvements, we are serious. If you demonstrate it, we'll give you the money. So that's why we are giving them 2,500 rupees just to talk to us for 20 minutes. It was also because we were worried that at some point, if a paid doctor is actually spending time looking at us, talking to us, and not making money instead of doing other business work, then at some point they might not want to participate. Right? Okay. So the contracts were fairly simple. Essentially what this says is, in this case, this is an output-based contract. We have some ceiling. We say, remember, these are negative outcomes, right? So that's why you have a ceiling. If you have a negative outcome that's below this ceiling, we will pay you. And from the way you would pay them is basically basically a simple linear expression. In this case, we would basically calculate what that alpha would be. And the way you come up with this alpha, which in this case is about 850 rupees for each percentage point, is, remember, we had only a finite amount of money from the World Bank. So we had to be prepared for the possibility that miraculously all the doctors show fabulous improvement and everyone brings PPH down to 0, right? So we say, here's 35% is what we found at baseline is the sort of average PPH levels we see in healthcare providers in communities like this. If they are able to bring it to 0, we need to be able to pay them. We can't make commitments that are bigger than what we can do. So what we had to do was essentially, in some sense, not that different from what a policymaker does. That is, offer people the chance to make this much of an improvement. If they make that improvement, the entire budget they have has to be distributed over that gap, right? In our case, we talked to a lot of doctors and struggled with this, that we could have taken, instead of an XI bar, we could have set an XI min and say, there is no way you can reduce PPH below 10%. It's biologically not possible. So we will restrict that range to 35 to 10%, and therefore the incentives are larger. The problem is the medical community just did not agree. They were like, no, if you do that, who's to say that doctors did not improve more? Like, for whatever reason, if we sort of hit this constraint, then we would find ourselves in this even more bizarre setting. So for a range of ethical and clinical reasons, this is what we ended up with. The inputs are slightly more involved. I'll take 5 more minutes on this and move on because this is going to get really dry at this point. So the problem with inputs is if you've seen any medical textbook, they are like this thick. And they are basically a whole series of things that doctors are supposed to do for any given condition. Now, something very simple. What do you do for a pregnant woman? Well, it depends at what stage of the pregnancy she is, what condition she comes in, and what other things you're supposed to do for each condition. So these inputs lay out all of these different criteria, and there are 5 domains of care: antenatal care, childbirth, postnatal counseling, maternal counseling, newborn care, and then counseling for the newborn when they're on their way out. The thing is, within each one of these, there are 50, hundreds of questions, things that the doctors are supposed to do. Something very simple like childbirth, which is that second category you're looking at there. Everything from when the mother comes in, how much history do you ask? Do you ask about previous maternal history? Do you examine the belly of the mother once every hour? Is it every 30 minutes? But that changes over time. How many times do you check the fetal heart rate? Each of this is an input. So now we run into this problem of having hundreds of inputs that need to be sort of gathered together, and we have to make sense of all of this information. So the good thing is that providers do not know what inputs are measurable. And this is where I'm going to take a slight detour. The problem with doing this kind of research in India, especially, is we don't have data. We can't use administrative data because it just doesn't exist. And if we tell doctors we are going to now reward you based on what's in the records, they will produce new records for you that are perfect, right? So you can't work with that setting. So because administrative data is not possible, and it was not possible for us to set up a new record collection system, data collection system, that would in itself become an intervention, we have to work with what I would call a third best in this case, household surveys. The problem, however, is there was very little information about what patients can reliably report. So we know Jishnu Das, for example, has this really nice paper that describes that about 2 weeks after you go to a primary care doctor, your recall drops precipitously about what happened. Right? So all those NFHS type surveys that ask 6 months recall, that's just bogus. And I'm fairly convinced that half that information means nothing at all. So in this case, what we did was we did our own validation study where we trained nurses to be flies on the wall and take copious notes from the time a woman walks into the hospital till she's discharged and goes home. We take very copious notes, take multiple shifts. So there's always somebody who's shadowing that one particular patient, shadowing them, taking notes of what happened. And then 2 weeks later, we show up at that woman's house after she's given birth and gone home. 2 weeks later, we show up and ask her what was done and go through the full list. This gives us some measure of which ones of these measures, these inputs, households are able to report with some amount of reliability. So in the reliability literature, you have these kappa statistics that you calculate to see the inter-rater reliability and stuff. Standard stuff. The good news is providers don't know which ones of these are measurable. So they know there are 50 things that are done. They know that we will be going to the mothers and asking them what was done. What they don't know is which ones are measurable and hence rewarded. This is important because if they knew that these 5 things are going to be rewarded inputs, they could very easily either game the system by just providing those inputs or training the mothers to sort of just saying, oh, look, I'm checking your baby now. I am doing this to you now. Just that kind of information would prime the mothers to be able to report favorable information on some counts. We also asked the mothers if they were trained to report or not, and thankfully that didn't happen like that. Okay, so that's how the input measurement happens, and this will come back to haunt us. This issue of having 50,000 inputs that need to be aggregated into 5 small little indices. Okay. So because this was done in the context of the government considering the option to develop a pay-for-performance program to contract with private providers across the state, what we did was first the government did a survey, they commissioned a survey to go and identify every single government, non-government doctor in rural areas whom they could possibly work with under a program like this. And the way it was defined was they defined public areas that are not served currently by large public facilities, taluka hospitals, district hospitals, for example. Anything in any area that's within a 20-kilometer radius around these large facilities were left out. And 20 kilometers was because the 108 programs in.
Hi, hello.
So the government did this survey and found about 120 providers. Now, the problem was we went back to verify whether that listing was done correctly or not, and we found a few additional providers during our field visits whom had been missed during the government sampling. And this is not surprising, right? This was a massive effort to go and do GIS mapping of every single provider outside the taluka areas. So effectively, then we got about 135 providers who are now randomized into these three arms. You will see that the balance is not perfect because of the way in which these 15 additional ones had found and they had to be assigned in the field without the field team having the ability to make these assignments. It had to be done in a way that it couldn't be falsified. Okay, so in general, we find that most of these providers, just over 50% are female. That's not surprising. This is for obstetrics. Over 59%, almost 60% of these guys have advanced OBGYN training. So this is an MD or a DGO at least. They're about 47 years on age, have about 20 years of experience, which is good. These are not fly-by-night operators. Even though they are in small rural areas, they've been there for a very long time. And that individual clinic has been in place for at least, on an average, about 17 years or so. Okay. So the study itself was fairly long. So in 2012, October is when the pre-contract visits and the surveys that I told you about first started. The randomization happened in 2013. And the first visit where we go in there and introduce the provider, tell them about the contracts, and then give them the rewards, and then we sign the contracts. Subsequently, we go back in post-contract visits. We try and understand, there were a couple of visits here during this period where we try and understand what they were doing in response to the contract. Mainly, if they're trying to use some innovative strategies, some people wanted to, say, for example, train their staff. Some people wanted to introduce better bookkeeping mechanisms. One provider, actually, this was not in our study, but another provider we saw in Rajasthan when we were doing prep work, had this really cool thing. They introduced a technique where they would, for cell phones that just started coming out then, he would take phone numbers and give it to a nurse. And one nurse, her job was to call every patient every day after she's gone back for the first 2 weeks, because that's when complications develop. So, those are small innovations. They can have a very large effect. And that's what we wanted to know. Basically, a whole year after when this contract randomization happened, the household survey started, and the household surveys were done very differently. So we wanted to get a fairly large sample. We had a sample, I'll show you the analytical sample is different, but in addition, we had the community sample as well of 10,000 people. The way we wanted to do this was not a standard cross-sectional survey. And this was because of the problem I told you earlier, that if you're asking for outcomes more than 2 weeks out, then you will have recall problems. And so from 13 to 14, this is a period of almost 8 months, our field team was in the field. And what they would do is keep track of every pregnant woman in that area. And once you know this woman is pregnant, she's going to deliver in 2 months from now, keep track. The day you find out that she's delivered, because we are also talking to the doctor and we are talking to in the community, so we would know. Once we do that, approximately 7 to 20 days post-birth, immediately after the birth is done, we go to the household to conduct this survey. So all surveys are conducted within 1 to 3 week, that 1 to 3 week period. That's the window in which all surveys are done. So it's a continuous data collection exercise to get around the recall bias problems. And then after that survey is done, at about 28 days or after 28, we call back again, unless if you are in the area, to check if the child is still alive. And that's because we wanted to get neonatal mortality data as well. Okay. So I told you about the 2 week period. This is not a cross-section survey. In addition, we also have data on provider expectations, demography, capacity before contract. We get some data on strategies the first 2 months after the contract to see what they're doing. And then after all the interventions and study was done, we did a follow-up survey where we gave them the funding with the money that they had, that their rewards added up to, and also collected some qualitative information about what they thought about being in the study and stuff. The analysis, again, because comes from a fairly straightforward experiment with just 2 treatment arms, the analysis is fairly straightforward. We use OLS to estimate the treatment effects here, and then control for all kinds of provider and household and provider characteristics, as well as the district enumerator fixed effects. So enumerator fixed effects in this case especially pertinent because we had created teams, as I told you, who were going to be traveling around the field constantly. So they were not this was not a giant army of enumerators. These were a relatively small team of like 15, 20 people who were employed for a very long time. So we needed to be careful about who was asking these questions, because especially if you think about asking a mother 2 weeks after her delivery, her experience of being in the delivery room and what she remembers or not, there's a lot of medical terminology and the ability to ask this information well. So you can see enumerator fixed effects becomes really important in these settings. In addition to the standard clustering, we have a major multiple hypothesis problem here. We have 4 outputs, 5 types of input indices, and 2 treatment arms that are crossed over. So if we don't do this, we're guaranteed we'll find all kinds of positive results. So we have to do the family-wise error rate in this case as well. And everything I show you here is accounts for multiple outcomes testing. Okay. So let's jump in, and this is the main set of results about the provider incentives on outputs. Relative to about 36% women reporting that they had some form of PPH, primary or secondary, in the control arm, the input and the output incentives report roughly about 7 to 8 percentage point reductions. Right? So that's about 20% reduction in PPH. That's pretty large. Preeclampsia, there's no statistically significant effects. If anything, it seems to have gone up. But it's not significant. I'll come back to trying to understand this particular result and pattern, if it exists at all. Trying to understand this because remember, preeclampsia is not an outcome; it's a risk factor. It's not something that happens at the time of delivery. It's something that happens when the mother gets pregnant. Right? So in some sense, this reflects possibly a positive selection of risks into the study areas. And we'll have to think about why that is. So in the appendix, we talk about why this particular finding can be, we pursue it further to try and understand if this shows risk selection rather than otherwise. Sepsis, there's not much going on here, but again, this is relative to a 6% on the control mean. These are 2 and 3 percentage points. So the magnitudes are actually not small, but they are imprecisely estimated. Part of the reason why this is also, I'll actually get into reasons in a second. Neonatal death, as I said, we were just woefully underpowered to look at anything at all. The control mean is 0.01. Thankfully, it's very, very low, so we have nothing to say about that. But the first question to ask when you see these sets of results is, well, sepsis, preeclampsia and neonatal death makes sense. Sepsis doesn't show very much going on here. Is it possible that PPH was the one that's most amenable to improvement, or is there a better explanation for why you find such relatively large effects for PPH but nothing else going on? But before we dig in there, remember we also were measuring the inputs among all these providers. So as I told you, there are hundreds of different inputs that are going to be now collapsed using an Anderson index, where you basically take an average of all of these and add them up, and then you use the variance across this entire set of outcomes to create a pregnancy care index, a childbirth care index, maternal care index, newborn care index, and post-council newborn care index. Just to tell you the difference between this is basically everything that the doctor did for the mother before she came to the hospital for childbirth. This is everything the doctor did for the mother during the time she was in the hospital for childbirth. This is what happens to the mother after the baby is born, but while she's still in there. So everything about how do you do better with breastfeeding, what are you supposed to do for your baby, taking care of the wound, so on and so forth. But this is happening in the hospital. care for the newborn. And this is what typically they do at discharge. That is, there is a bunch of things that doctors are supposed to tell the patients when they go home to look out for warning signs, both for the mother and for the child, and what you're supposed to do to manage minor complications and stuff. The only thing to remember and note here is all of these are very small effects and are close to zero and not significant, with the one exception of this one. And remember, this is coming from results that have been adjusted for multiple outcomes testing and everything. So this was surprising, that essentially post-born natal newborn care counseling goes down a lot, but only in the output incentives, not for the input incentives arm. Okay, we'll come back and try to make sense of this when we're putting the whole story together. Okay. All right. So just to remind ourselves, we ran the numbers and we don't see very much here. But the problem is we're taking about 50 different things that a doctor could do for a mother that's come into childcare. No doctor is going to do all 50. Let's say you and I are two patients who come in. You have a very different set of complaints or presentation. You have no health history. You're a healthy young woman. I come in and I have had multiple miscarriages in the past. I've had all kinds of other health problems. The things the doctor may do for you might be different from what they do for what the doctor does for me. Rightly so. That's exactly what clinical medicine is supposed to do. The problem is we take 50 questions, 5 of which apply to you, 5 of which apply to me, and 40 others that apply to none of us, but they apply to other patients, and combine all of that into one index measure. And so inherently, our construction of the index measure with inputs, complicated inputs like this is a problem. This is not necessarily the right way to do it, but in hindsight now I can see that it was not. Sadly, reviewers will not let me change that and come up with my own index. Exposed, which is much more targeted to the types of patients and the inputs that are required for the patient. Instead, what we do is to say, all right, we know that there was only one outcome, PPH, that actually we seem to find improvements. From clinical medicine, we know that there are a few things that doctors can do to improve outcomes on PPH. Do we at least find evidence that they did better on those outcomes? That's a reasonable question we can ask. It was not part of the pre-analysis plan. But what we find is, first thing, there's something called active management of third stage of labor. That is, after the baby is delivered and the placenta is still coming out, at that time, the doctor should not be letting the mother be unattended. Instead, pay attention to that final stage of labor where the placenta is going to come out. Cord clamping happens early so that you don't lose too much blood. Nowadays the recommendations at that time was to do control cord traction, so that if the placenta is not coming out automatically, you do very gentle cord pressure and keep it constant, so that when the placental separation happens and it comes out. And then there was also abdominal massage, which in 2008-9 was considered best practice, and now WHO says do not do abdominal massage. Okay. But at the time when this study happened and the guidelines were given out, it was still considered best practice. Then there are two specific actions that are most closely related to PPH. One is administering what we call parenteral oxytocin drugs. So these are drugs, essentially an injection that helps the uterus contract. It serves two purposes. It pushes the placenta out, but it also prevents bleeding because it constricts the blood vessels, right? So that's a good thing. And the second is, then the second part is the tricky one. It's a negative outcome, which is manual removal of placenta, which happens essentially when, if you've not done all this first stage, active management of third stage labor stuff correctly, like if you yanked on the thing a little too hard, or if you ignored it and all of these problems, you will have higher instances of an unremoved placenta. Only part of it comes out. So when the placenta comes out, it's supposed to have this nice, complete, intact, shiny structure. There should be no blood vessels or anything. It's nice, complete, intact. If you see holes missing in there, you know there's stuff left in there, and that's what's going to cause the bleeding. Then they have no choice but to manually extract it out, scrape it out, and it's painful, ugly stuff. So that's the second thing we can look for, right? And so when we look into this, what we find is the following. The first one, columns 1 and 2, is availability of oxytocin drugs. Now, the good news about this table, it doesn't come from data that the doctors gave us ex post or asking the patients. Obviously, the patients don't know about drug availability. This is data that we collected when we went back for our management style consulting visits to ask doctors what they are doing. And we would go into their inventory rooms, into their stock inventory rooms, and take stock of all the equipment they have and see what kinds of drugs they have. So obviously, we collected a lot of data. We look at this one because this is what we might hope to find some differences on. And sure enough, what we find is roughly about a 7 percentage point increase in whether or not they have these the one key drug that they're supposed to give. Okay. We also ask mothers if they were given the drug, and before we include all the fixed effects and stuff, it seems to be significant. But frankly, I doubt mothers would remember what drug they were given when they were in the middle of delivery. So let's not oversell that point. Massage after abdomen, no effect in the output incentives, but the input where they were told, look, here are the guidelines, follow the guidelines. Again, you see a 7% increase in there. This is column 6 I'm talking about. And then the last one, the manual removal of placenta. This is, remember, it's a negative outcome. It is an outcome that you would see if complications come in. If you do all the right things, you should see fewer instances of the complication, which means you should see fewer instances of the manual removal of placenta. So a negative outcome here, negative result here, is consistent with the story that maybe they are actually doing the right thing for preventing PPH. Right? So you see a negative 7% on the output incentives and 5% on the input incentives as well. Okay. Then we said, all right, let's just quickly look at, before we go into trying to put all of this together, let's see if we overpaid these guys. So I think somebody had asked this question about the marginal productivity. We initially wanted to think about this as the efficiency of our payments. When we first started writing drafts of the paper, we were thinking of it in terms of efficiency. The problem is we did not offer a contract which was sort of describing payments across every different level of improvement. We just said one rate and that was it. And so the problem is that we cannot necessarily say that input contracts are more or less efficient compared to output contracts based on this alone. All we can say is, rather than looking at the actual payments that were given to the input-based providers, if we had paid them for those same outcomes based on the outcome-based payment regimen, we would have paid them a lot more, which is another way of saying maybe we threw a lot of money down the drain for the output contracts in this case, which is, that's one interpretation. The other is maybe they actually had some improvement either. Sadly, because we did not design our contracts differently, we are not able to ask that question about the marginal productivity of labor, because we could have then said, here's, if you show 1% improvement, we'll give you so much money. If you give 2%, we'll give you a different amount of money. And we could have possibly written out what the production function looks like and then paid people based on that, which there's just no way to do that. In some sense, you want to run these kinds of experiments 2 or 3 times. We just didn't have the budget for doing all of that. Okay, so all I will say is the average payments to outputs was much higher, about roughly 4 times as much than the input-based payments, although the outcomes we see are roughly comparable, as you saw earlier. Okay, so then now that you know roughly what the overall effect is, it's useful to turn to the key question, the type of agents. We hypothesized that these higher skill providers, those with MBBS plus, they have more than MBBS, not MBBS alone, whether it's MD-DGO or something like that, they might be able to innovate and do better. So I have 2 sets of tables there. One, this is the impact of incentives on PPH, which is the main outcome. The others did not really change, so then there's no point in looking at those. Impact on PPH by provider qualifications. And what you find is, among the MBBS plus providers who are in the output contracts, the effects are much larger. Among the MBBS plus providers in the input contracts, it's smaller, it's still going in the same direction, but it's not as large and it's not statistically significant either in this case. But then the effect among just the MBBS plus providers All those who are in the input contracts and output incentives, it's not very much. So when you do the linear combination of these, what you find is being an MBBS provider, which is here, in the input-based incentives, you're doing fine. You're at least showing 5% reductions. It's statistically not different from zero, but it's at least in that neighborhood of the same effect here on the input incentives of MBBS versus non-MBBS plus versus the MBBS plus. It's about the same. The real effect, what we find is when the MBBS plus providers, the highly trained providers, are given output contracts. In the input contracts, it doesn't really matter whether you have the advanced qualifications or not. So then we say, all right, if that's the case, does this whole story of innovation strategies really pan out? Again, as I showed you, one clue there was already we were seeing that the oxytocin drug storage was happening. But when we go back and look at our data and we asked, what percentage of them actually implemented a new strategy, and this is dichotomized for simplicity's sake, we find that in the output contracts, the MBBS plus providers, about 36% of them reported implementing a new strategy, versus these same types of MBBS plus providers, when they are in the input contracts, a lot fewer of them are implementing these new strategies, which is consistent with this idea. You take a highly trained provider, you give them the opportunity to innovate and a big carrot in front, they might be able to get there. The same thing when we run the same exact table, when we run it with the MBBS providers, we don't find anything at all in there. Okay? So this is essentially what we find. I'll then take a couple of minutes to talk about multitasking and then switch gears to tell you about the psychology findings that we had. Remember, I pointed out a bizarre finding. That is, the postnatal care was the one index that we found that was actually negatively affected, and a fairly large effect on that postnatal care index, which basically said that providers in the output-based reward arms, did worse in giving advice to mothers about what to do for their children when they get home. There was no effect on the input-based arms. The output-based guys did very badly. So we went back and looked at the expectations that we had elicited among these providers, and we asked them, which one of these outcomes is most important for you as a provider to improve, and which one is the least important. And not surprisingly, neonatal mortality in this case, and then sepsis in that order, was among the least important to improve in both of these settings, right? And so when you think about, if this is the underlying set of expectations that the providers come to the table with, and everyone knows that PPH is most important, then regardless of which treatment arm you're in, you're always focusing on this one. If you are in the output treatment arm, then you're much more subject to response based on your underlying priors about what your expectations are. And in this case, then it starts making sense why the output-based providers are responding by not doing enough on postnatal care. They actually don't think this is very important at all to start with, versus the input-based providers are just doing what they're told, and that seems to make sense. That's one possible explanation. Of course, there could be others as well in there. Okay, so then let me just conclude with a couple of, one more slide on this one, and then I'll switch gears. So the key thing that we take away from here is both these contracts, turns out, can have fairly large effects. So the pay for performance literature that finds large effects is possible, but also important to remove. Remember, we found effects on 1 out of 4. If we had done the reporting like some of the other major papers in this literature had done, we could have shown you one paper, one result, and it would look very big and impressive. But it is because of the fact that now it's become sort of much more commonplace to have your pre-analysis plan and declare everything up front, you know that actually out of the 4 outcomes, only 1 worked, and out of the 5 outcome inputs, nothing worked, right? In terms of heterogeneity, actually our findings seem to suggest that maybe developing country governments have been doing something right anyway. They're working with vast armies of low-skilled providers. So to try and offer them these output-based contracts saying we will give you better pay or incentives based on some patient-level health outcomes expects them to be able to innovate on the field. And that might just not be possible. Instead, Giving the low-level healthcare workers incentive contracts that say, you increase registration by X amount, I'll give you some amount of money. You increase immunization days by these many days or these many numbers, I'll give you some amount of money, essentially might be the right way to do it if this finding actually holds true. And where we're going with this is, it gets back to this issue that I mentioned earlier, is the next frontier of research in this field, especially around service delivery, is to think about, can we bring in the right kinds of agents? That is, if I'm trying to hire healthcare workers, then I want to think about the tasks they have to face, what tasks they have to complete, what kinds of skill levels I can attract, and maybe design contracts better for that kind of skill level. We also use this opportunity to try and learn a little bit about personality traits. So yeah, the last couple of minutes, I just wanted to flag to you, when we were doing this, the literature, there was this big push on trying to understand the big 5 personality traits and how they affect performance. And so among all these doctors, we had also tried to measure their personality traits. And the 2 main ones that are correlated, known to be correlated with labor market outcomes from the labor econ literature, are conscientiousness and neuroticism. So what we did was, conscientiousness is basically a trait that shows that you're dependable, you have organizational skills, perseverance, achievement-oriented thinking. You're this go-getter. Neuroticism, it doesn't mean you're neurotic. It means you're somebody who gets very sort of anxious, you're worried, you might get angry when you face sort of stressful situations, you're very insecure, right? So it's the exact opposite of being emotionally secure. So the thing is that we've seen in the labor econ literature a number of sort of studies that have shown that these things affect performance. However, the predictions are slightly mixed, right? So we basically, what we find in our study is that providers with high levels of conscientiousness and providers with high levels of neuroticism, they don't show improvements with incentives. And so let's unpack that a little bit. What we find is that the providers with high levels of conscientiousness have already an average high level of performance, right? So if you think about it as the dummy variable, the coefficient on this, I can show you the numbers later as I have it in the backup slides, but we don't have time. I'll just tell you. So if you think about it as a dummy variable, you find a large effect on the dummy variable itself. The interaction with the incentive, however, has no effect, right? So the effect, the dampening, in fact, if to the extent it has any effect, it's slightly negative, and it's not that trivial either. So it's what we interpret that as a crowding out effect. This is what a lot of psychologists have been telling us. If you have agents who are highly motivated, doctors who want to make the world a better place, and you bring them in, sure, their average level of performance is already going to be very high. That's the conscientiousness story. Now you expose them to incentive contracts, some of them actually do feel belittled. They say, this was not, I was not doing this for making money. You came around and like made this a money game. It sort of made me disinterested. And remember the qualitative studies I told you we did, where we did interviews. This was not untrue. Some of the charitable hospitals that were run by nuns and stuff with the doctors there, they were the ones who told us exactly stories like this. So it's consistent with this idea that high conscientiousness is correlated with high performance, but then the effect of incentives might exactly be the opposite, which is what psychologists have been telling. And the high neuroticism, this is now very consistent with this story on choking. So in the high stakes sports literature, what you find is that athletes at the highest levels of performance, the ones who have high levels of neuroticism often choke when they are on the highest stage. They'll do fine when there's in the heats and stuff, they'll do great. And then when it comes down for like that Olympic gold, that's where they're not able to perform. And we find this among high stakes stage performers, high stakes sports performers as well. This idea that high neuroticism providers are going to choke when it comes to be high stakes. Again, reason why this is important, if you're thinking about it as managers who need to think about strategies to motivate our own staff, and if our staff, in this case healthcare, they're all high conscientiousness workers, then perhaps incentive contracts might not be the right thing for that group. right? And I don't expect that most of us will use big five screening tools to find people who are high neuroticism and then rule them out. But it's not that unusual. Frankly, I've seen in my younger days, before I went off to college, I wanted to join the Air Force. Actually, I ran away from medical school at one point to go join the Air Force. And I went through their services selection board interview. The thing I took away from there is the Army does this. They go through a very, very rigorous psychological testing program before they select who to take in. And if they can do this for the entire batch for decades that they've been doing it, it might not be that bad an idea for us to sort of think about adopting what the Army is doing so successfully in other parts of recruitment as well. Anyway, so I'm out of time. I should probably stop. That's all I have for today. Thank you.